Okay, good afternoon. I'm Dr. Werapat Pathanasri. My advisor, Dr. Vishan Kachanathawan. I'm from Bamrungrad International Hospital. Today I'm going to make a presentation on interesting topic, subscapularis tear, updated classification and treatment strategies. We always fight with subscapularis tear. Gilswell coined the term iteration in 1994, and Stephen Burkhardt introduced arthroscopic repair of subscapularis. And they both update their insights into the management of subscapularis tear 10 years later, which I will present to all of you here. Now, we still miss it. From last year's literature in the US, out of 1,000 patients, radiologists miss 50% from MRI alone, and experienced shoulder surgeons miss almost 30% from MRI and clinical exam. So you have high chance of missing it preoperatively. What will happen if you miss it? From the recent literature from Korean, they review the failure case of rotator cuff repair, and out of 50 cases, there is 43% of neglected full thickness tear of subscapularis with there is propagation of fatty infiltration and a pretty high repair rate of almost 40% after revision surgery. Can AI help? From the last year literature from the Mayo Clinic, they developed a machine learning or so-called artificial intelligence. And the AI can predict subscapularis tear with 85% accuracy from imaging alone. However, there needs further development. So first, help yourself, learn today and no missing tomorrow. So first, let's review the basic anatomy. This is a classic picture from the classic literature. The subscapularis is the largest and the most powerful rotator cuff muscle. And the upper two-thirds is a tendinous part and the lower one-third is muscular part. Sorry. Also, for the Lafong classification is the most popular and mostly based on tear size. There is 5 types of Lafong. However, there are several drawbacks, and that's why now we have many classification systems. First one, not all Lafong 1 is the same. 80% of subscapularis tear is Lafong 1. However, you can see in the image these are Lafong 1, but there is a big difference in the big variation in the Lafong 1. So if you use Lafong, you're going to miss this variation. So many doctors try to modify the Lafong 1 subclassification, like 1A and 1B like this. However, for the U classification, he introduced the concept of footprint concept to subclassification in more detail. If you look at the footprint of subscapularis, you will see that there is different facet orientation. The first facet accounts for upper one-third of tendinous part, and second facet up another one-third, and for the third and fourth facet, lower one-third muscular part. So we mainly focus on the first facet. For the Lafong 1, it is a partial tear of upper one-third. We magnify the first facet here. It will equal to the partial tear of the first facet in U classification. In the U1, its tear will be minimal like this, and the 2A is less than half of first facet, and 2B more than half of first facet. For the Lafong 2, it's a full thickness of upper one-third tear. It is equal to U3. And how do you know it is partial tear or full thickness tear? You said that he tells that we need to look at the most lateral tissue, which is called lateral hood. This is the last tissue to tear. How it looks intraoperatively? If you look intraoperatively, you can see that the lateral hood here is a partial tear in the partial thickness tear of the subscapularis. While when it is full thickness tear, you can see the complete tear of the lateral hood like this. And the Matter-Schlager classification, he tried to simplify the classification by just measuring it intraoperatively using a calibrated probe like this in transverse columnar plane, and will lead to the classification here. And the Lafong classification not include some hidden lesion. The first one is intratendinous subscapularis tear. This is a tear inside the tendon, but intact articular or bursal site. Intraoperatively, we can see a hump site like this, and no associated pathology like bicep pulley. The Torsong classification also include the anterior bicep sling, So, but the Lafong not include this. So for the update treatment, Gilwell, who coined the term hidden lesion, updated his literature, and he described several techniques to define the hidden lesion, which I summarize in easy to remember here. Let's go through each by each. So first of all, you need to switch cameras from 30 to 70 degrees can increase your visualization dramatically, and sometimes subchromic view can help. So there is a clue, sentinel sign and comma sign. Sentinel sign was described by Sahu and Lefong. It is an undersurface lesion of bicep tendon, especially at anterior port. If you look at it, how does it occur? If you look at the superior insertion of subscapularis here, you will see it close approximate with the long head of bicep tendon. It is the most important bicep stabilizing structure. And when it's tear long head of bicep tendon will sublux to the exposed bone. And that's how the sentinel sign occurs. And for the comma sign, what is it? Comma tissue, actually I like to think of it as a communicating tissue complex linking supraspinatus and subscapularis here. In the anatomy, it's actually a CHL and SGHL, which is actually a bicep sling. So the comma tissue can view as a displaced bicep sling. So how to find it intraoperatively? First, you define the glenoid, and the structure that is vertical and parallel to the glenoid is comma tissue, like this. If you pull it laterally, you can see the upper border of the subscapularis pretty obvious. And then sometimes you need to push, you need to move. Flex internal rotation and posterior lever push can help. You will see that after doing the maneuver, you can see the normal subscapularis insertion quite clear. And when there is a tear, you can expose the footprint. But in some cases, you will see the non-retracted subscapularis tear. You can see now there is no insertion. See. This is described by Yamakudo in 2020 as a floating subscapularis tear with intact transverse humeral ligament, why no retraction. Sometimes you need to cut the medial pulley. When you cut it and you debride it, it will expose the tear. So the key image to remember here is a normal subscapularis insertion and comma tissue. Now we see the tears. What's next? So for the conservative treatment indication from EZ course 2024, the partial tear fraying along to no split. Look at the evidence from they show you that prospective randomized control trial for the Lafong 1, he compared repair and debride orally with a clinical and 5 year and MRI more than 2 years. What he found is that clinical and MRI outcomes no difference, except subscapularis strength at 5 years. And there is another two studies that support that no difference in clinical outcome. For the surgical treatment, there is a full thickness tear, acute traumatic tear, and young active symptomatic tear. So open or scope. Actually, in difficult situation, huge retracted questionable tissue quality, mini-open subscapularis repair can save your time with good result. It get a clear exposure, effective cup mobilization, and easy anchor placement. If you look in the literature from the biomechanics study, there is the biomechanics study to compare tranosseous modified mesoneline repair with the arthroscopic repair. It is superior to scope in a large fluid cup tear. And look at it in a systematic review that no difference in clinical outcome or complication. Another comparative study, also no difference in clinical outcome and MRI assessment 4 years post-operatively. However, be aware that it will be less operative pain in the arthroscopic repair. Learn how to scope. Also, arthroscopic repair technique. Repair subscapularis first, don't cut comma tissue, triple release, and bicep procedure if indicated. So look at this comma tissue. Look at the video.
Tissue, which links the subscapularis.
Yeah, you can see the comma tissue here. It connects to supraspinatus with subscapularis. And do you see what happened after we threw the comma tissue laterally? The subscapularis and supraspinatus automatically reduce. So this, you can see by your own eyes that why you need to preserve this tissue. And there is another study in 2021 at the American Journal of Sport Medicine that stabilizing common tissue technique also provides superior biomechanics compared to the single row repair. So don't cut common tissue. Why? I have three. These are all the rationale. Localized subscapularis tear facilitates subscapularis release and reduce supraspinatus after subscapularis repair and stabilize the repair. So you need to learn how to do the triple release, posteriorly, superiorly, anteriorly, like this, okay? And for the bicep procedure, tenodesis or tenotomy, the benefit is that it will protect the subscapularis repair because the persistent subluxed biceps can stress subscapularis repair. It also improves the visualization during subscapularis repair. However, you need to know that it is a limited number of evidence, no biomechanics study, no comparative clinical study. So the indication for most bicep procedure is bicep instability or tear. And this is the preferred by most surgeons in several reviews. So what about the single row and double row repair? There is a systematic review on biomechanics in 2022 from Stanford University. They reviewed 6 studies on biomechanics in this issue. So now there is inconclusive evidence to determine which construct is better due to the lack of homogeneity. And what about the clinical comparative study? The first clinical comparative study done by Korean. This is a retrospective cohort study. It allows for 2 or more and follow up for more than 2 years. No difference in clinical and structural outcome. The repair rate also no difference. How about the corticoplasty? Corticoplasty, there is a clinical comparative study like this, which found no difference in clinical outcome, whether you do a corticoplasty or not. However, the recent literature in 2025 revealed that they favor corticoplasty, which improves clinical outcome like pain, function, range of motion. However, the issue of corticoplasty is still controversial and not routinely necessary. When is too bad to repair?
Irreparable.
Yeah, it's irreparable. It's truly irreparable and functionally irreparable. For functionally irreparable means it can repair to the footprint, but it has high failure rate. And for easy to remember when you cannot repair it, bad center, bad muscle, and bad tendon, like this. So for the irreparable, for a young active without arthropathy, we recommend tendon transfer or anterior capsule reconstruction. For all low demand arthropathy, maybe reverse is a choice. What about the pectoralis major and latissimus dorsi transfer, which is introduced by Bassem El Hassan? So in a horizontal plane, latissimus dorsi has better vector. However, from the systematic review in 2019, compare different several studies, you will see that no difference in clinical outcome and complication. However, this needs more high quality studies. For the anterior capsule reconstruction, which use the concept as SCR. It is a static stabilizer, provides scaffold for rotator cuff incorporation. However, the main drawback is that it lacks long-term clinical study. The first one who reported a clinical study is Youngly in 2023. He reviewed 18 cases, used human dermal allograft for anterior capsule reconstruction and follow up more than 1 year. He showed that almost 90% of the graft heal at splenoid and humeral sites. The clinical outcome improvement in all parameters and MRI reduced anterior translation. However, this is not a comparative study. And for the reverse shoulder arthroplasty, no specific data on reverse shoulder for irreparable subscapularis tear. However, there is a risk factor for poor outcome, young age and active elevation more than 90. So this is the take-home message. Don't miss subscapularis tear by easy to remember, camera, cruise, pull, push, and clean cut. And open repair is a good option, especially in large retracted tear. And learn to scope effectively. Repair subscapularis first, triple release, don't cut common tissue, and biceps procedure if indicated. And for the irreparable, tear, tendon transfer, or anterior capsule reconstruction. Thank you for your attention.